Nope, not often.
It was hematuria.
That's right. Hematuria, most of the time. Yet another reason why we just can't let hematuria walk away without explaining why this patient has it, okay? You're going to find cigarette smoking as risk factors for almost all GU cancers, particularly renal and bladder, okay? Those are the two most important subpopulations. If they smoke, you cannot let them, if they have a smoking history, you cannot let their hematuria go unexplained, okay? Now, bladder much more prevalent than renal cell cancer, but another possibility for microscopic hematuria, whereas bladder cancer is going to be gross hematuria in most cases, okay? So cigarette smoking, just not good, okay? You guys, I don't know if you've heard that before, but it's not. So, there you go. So usually, the 6th decade, we actually had a student who shared his mother's cancer, renal cancer journey with me. Where do you think potentially a common site for metastasis from renal cell cancer would be? Huh? Bone? Did I hear bone? Back? Yes. Back too, yeah, or lungs sometimes, but bone, just local invasion, right? This lady, this patient had a severe renal cell carcinoma, stage 4 at presentation, but her presentation was severe SI joint pain, low back pain, okay? Again, you guys go back to the red flags of low back pain. What are some of the red flags of low back pain? Worse at night, fever, chills, night sweats, unexplained weight loss, right? Saddle anesthesia, not so much because this isn't cardiac minor we're talking about, but there, again, things metastasize to the low back, cause regular low back pain in an older woman without much of a smoking history. Well, that's not a common presentation. Maybe it's more likely arthritis. It is more likely arthritis, but in this case, it wasn't. By the time she got to the MRI, it was invasive. It had metastasized, it disseminated, and unfortunately, not a good outcome. But just understand that these red flag signs are very important for you to ask for PERT negatives. They're as important if they're not there as if they are, okay? Specifically for your documentation, so just renal cell carcinoma. Oftentimes, microscopic hematuria. The likelihood, whoever said mass back there, that is going to be a pretty remarkably large, like everybody's palpated, I'm going to put the air quote, everybody's palpated your kidneys and no renal masses, and you're just kind of like doing one of these numbers, right? Anybody felt a spleen while they were doing NP? Anybody felt kidneys, right? You're not supposed to, okay? If you can feel a renal mass, if they complain of a flank pain or a renal megaly, then that is probably a pretty large and probably fairly advanced cancer. So the triad, the classic triad of presentation is hematuria, flank pain, and an abdominal mass or a flank abdominal mass. Unlikely, okay, to show up that way. More likely just to show up incidentally, right, on a microscopic hematuria that we chase down. When I have B symptoms, have you guys talked about those anywhere? Okay, so the old Ann Arbor classification would have stage 2 Bravo, for example, B. B symptoms, literally Bravo, meaning fever, chills, weight loss, night sweats, right? Those are the unexplained weight loss, excuse me. So the new cancer classification systems don't have those, the Lugano classification don't have those, but the old ones, so if you hear B symptoms, that's what I'm talking about. Fever, chills, unexplained weight loss, and night sweat. Okay? What do you think that means? If they're present, it's bad. It's late, right? Those are constitutional symptoms. Like what is the kidney? It's surrounding the kidney is what? The renal capsule. It's a contained thing, right? So what that means is now it has broken out of the capsule or it has invaded into the nephron mass, meaning it is down into the blood supply, and now that is where it's disseminating. So when we're waiting for B symptoms to show up, we're waiting too long, right? Because now those are signs of metastasis. Bad. Physical exam usually, completely asymptomatic patient usually feels fine. Not usually going to feel that renal mass. If you do, again, more concerning, all right? And then obviously other signs of advanced disease, lymphadenopathy, you guys know that one, right? So we're talking about local and regional metastasis to the nodes. A varicocele is, anybody know what a varicocele is? You guys talked about that in pathology. It's a swelling of the pampiniform plexus of your spermatic cord, all right? So when that engorges, it becomes a sort of like a varicose vein in the spermatic cord. Patients have symptoms of heaviness and swelling in the hemiscrotum. What that could mean is that has, how that develops as a varicocele, right, is the spermatic vein dumps into the renal veins, right, eventually. So if there's a neoplasm growing and obstructing the return of that blood in the renal vein in that area, then downstream it can cause that back pressure and create that varicocele. That'll make more sense in the urology section, but again, it's one of the reasons why unexplained sudden onset of a varicocele, usually we're looking for something neoplastic or some kind of growth. All right? Laboratory workup should make sense. Okay? What kind of anemia are we probably going to see here? Probably normocytic. Okay, probably anemia of chronic disease. In this case, a default. It's going to be one extreme or the other. It's going to be a default of a lack of EPO production or an overproduction, so more like a polycythemia presentation. Which you guys haven't talked about polycythemia yet, have you? So polycythemia was mean a lot of cells. Yeah, overproduction of all cell lines. Usually called polycythemia vera rubra because most of the time what's affected is erythrocyte line lineage. So either underproduction, overproduction, but some sort of anemia, all right? And so what are the overt signs of anemia? Or not overt, what are the lab diagnoses of anemia? Simple, decreased H&H, yeah. That's where it goes, right? Decreased H&H and you take it from there. Okay. CT, MRI, this is where we're gonna need that, to characterize the lesion entirely and to see what metastasis there are. And then from there, other radiographs as necessary. What we need for diagnosis of the renal carcinoma, though, is the CT or MRI. Okay. And again, any kind of mass, solid renal mass. I know it's very difficult to see, but you can see this little chestnut right here that doesn't belong there, right? So any solid renal mass needs to be treated like cancer. Okay. And we'll contrast when we talk about cystic renal disease tomorrow. Very different. And anything solid in the kidneys, you got to find it. And let me tell you this. Not even just microscopic hematuria. What's another way do you think that we will find a lot, quote unquote, of renal cell carcinoma, or renal cancer? Incidentally, how? Exactly. Scanning for something else. Scanning somewhere where we capture the kidneys because the patient has diverticulitis or an unexplained abdominal pain or whatever, and they find that. That's exactly right. Okay? And then let me ask you this. What do you do with that? What do we do? How do we dispose of this patient? Referral to urology. Why? Somebody got to get cut. Exactly. We need scalpels, not calculators. Not at this point. Okay. So, if this is too subtle, let me know. Okay. And don't worry, I don't care. I and you, I don't care what kind it is. I don't care about the epidemiology of the specific, pathologic subtype. Does it matter to us? Right? Who does it matter to? Oncology. Why? Because they have to tailor their treatment to the specific subtype. Because each one of those subtypes has a different tailored chemotherapeutic regimen that works better for it. Okay? But to us, there's a thing, it doesn't belong there. Go to urology right now. Call urology. Hey, I've got this patient, I have a solid renal mass, I'm sending them to you now. Okay? And the rest of this stuff, there are benign renal masses. Okay, there are benign solid renal masses. What does that mean? How does that change the course of treatment for your patient where you discovered a renal mass? It doesn't, exactly. In primary care, it doesn't change. We send them because we want to. If you're a patient, Do you want me to be 99% sure you don't have cancer? Exactly, no. So we send them, okay? There you go. And most of the time, if we catch it early enough, take it out, right? Contained within the renal capsule, take it out. Even if it's broken in the renal capsule, sometimes take it out. Local dissection, but take it out. Surgical nephrectomy, almost universally. In other cases, certain cases, like if the patient only has one kidney left, or if they have chronic renal disease, maybe a partial nephrectomy, but for all intents and purposes, the treatment is to take out that kidney. Take it out completely, all right? And the cancer comes with it. And sometimes they do pretty okay. All right. Oh, let me go back to this. Has anybody discussed with you what active surveillance is versus watchful waiting? They delineate the two. What is active surveillance? Huh? It's not just scanning. It's we're bringing them in on a schedule to either do labs, do scans. We are actively watching this patient on a fixed time schedule. What is watchful waiting?
Hey, let us know if anything happens.
Let's see what happens. You know what I mean? Yes, exactly. Okay, so they're two different things. We're not just going to send this patient and see you next year, pal. Nope. I'll see you next month. Or sooner if it starts to get worse, right? Prognosis. See, if we do our job, or if the patient presents to us in time, that's not bad, right? A cancer we can cut out. That's okay. That's pretty good, right? If we wait for lymphadenopathy, positive abdominal exam, B symptoms to show up, not so good, eh? Right? No. All right? And then others. Does that matter? Does any of this matter? No. Really? To primary care? No. What are we going to assume? We're going to assume that it's cancer. And we don't really care which kind of cancer it is. Then, oh, it's benign. It's an angiolipomyoma. Or it's not renal cell carcinoma. It's something else. Fantastic. Okay? Doesn't change our course of treatment. Or our approach to treatment, I should say. Okay? Any questions about renal cell carcinoma, or renal cancer, I should say? Okay, pretty straightforward, right? Pretty straightforward. Other cancers, again, this is other urothelial cell. Don't forget that that's the lining of the external GU tract, right? So that everything from the renal pelvis down is urothelial cell. Okay, so pure ureteral cancer is weird, and we will talk about bladder cancer in the next block. So we're really just concerned with the kidneys right now. Wilms tumor nephroblastoma is a renal carcinoma of youth, childhood. This, by contrast, will typically present with an abdominal mass because it grows pretty fast. So you have a kid that's generally otherwise okay, healthy, but they have this unilateral abdominal mass, and it's usually unilateral. Another thing about it, usually doesn't cross the midline for some reason, so it grows out into an abdominal mass. But what you're feeling isn't some sort of, it's a renal megaly, it's a growth of the kidney, okay? So, and this is how it presents. Patients are brought in, maybe they're acting a little sluggish, maybe they're having a little abdominal pain, and they have this big thing on one side, okay? Hypertension may be common, gross hematuria sometimes, but really this is the one, how it shows up, all right? Excuse me. So you can sort of make out with the red lines, of course, that this side's a little bit flatter. And again, if you're doing this physical exam, you'd be able to appreciate that this mass is here. And general examination, so you don't smush it. Okay. Labs, okay. Initially, ultrasound. We don't want to send kids into a CT scanner if we don't have to. Every unilateral abdominal mass isn't cancer, okay? So characterize the lesion, then ultimately what they really do need is a CT or MRI once we find out that it is consistent with nephroblastoma, okay? So really with kids, just like with pregnant patients, anybody you don't want to expose radiation to if we don't have to, just get that ultrasound first. All right, urgently of course, but then send them to the radiograph if we need it more. And treatment, what do you think? Send them, like we're not doing anything. That's the end of primary care. Ultimately, the good thing is that kids do very well, all right? And the whole bottom of this slide, if you guys haven't heard of this, you will, and on National Comprehensive Cancer Network, you can sign up for it. It's a website, put in your login and password, put in whatever cancer you want, and it tells you exactly what the treatment and workup protocol is. It's really handy as a provider. You don't have to remember those things because again, it's not in our hands, but ultimately what that says is patients who have a better type of histology are more likely just to get chemo, and then you work that all the way down to a much higher risk or worse type of cancer where surgery, chemo, and then we're talking about neoadjuvant and adjuvant chemotherapy, so before and after surgery. So it's worse. I guess the worse cancer, the more intensive the treatment. That's the takeaway. So don't spend too much time, or don't spend any time trying to memorize this stuff, okay? But the good thing is, the takeaway, these kids generally do pretty damn good with this. Kids are very resilient, surprisingly so, okay? Again, that's all I have for today. Does anybody have any questions about cancer? I told you that one is right down the middle. Anything that was confusing at all? All right, well, we're done. I'm done with you. Go eat some lunch and